Good afternoon or good morning, depending on where you're joining us from today. Welcome to today's webinar. This is Reviewing Policies for Equity Impact, a tool to support equitable maternal health outcomes. I am Allison Northrup. I'll be your moderator for today's webinar. I'm the Associate Director of Public Policy and Government Affairs at the Association of Maternal and Child Health Programs, also known as AMCHIP. I also serve as the Policy Core Co-Lead for the Maternal Health Learning and Innovation Center, which is hosting today's webinar. Next slide, please. The Maternal Health Learning Innovation Center, or MHLIC, is a new national resource focus. It's a resource center focused on accelerating evidence-informed interventions, advancing equitable maternal health outcomes through engagement, innovation, and policy. MHLIC is grateful for funding in partnership with the Health Resources and Services Administration. Next slide, please. A few housekeeping notes. We will be recording today's webinar, and we will share that recording via email with all registrants. Also included as follow-up will be the slides from our presenter today. And these resources will also be added to our resource center at maternalhealthlearning.org. All participants are muted, but that does not mean that we don't want to hear from you. We'll have time for Q&A at the end of the presentation, so please use the Zoom Q&A box or the chat box to enter questions. And if you do use the chat, please be aware that you have the option to send your question to all attendees or to just the panelists. We'll also have a short evaluation survey at the end that you will see a link to. Next slide, please. It's now my pleasure to introduce our speaker for today's webinar, Dr. Cynthia Osborne. Cynthia is the founder and director of the Child and Family Research Partnership, and she leads its national Prenatal-to-3 Policy Impact Center. She's also Associate Dean for Academic Strategies and Director of the Center for Health and Social Policy at the LBJ School of Public Affairs at the University of Texas at Austin. Her teaching and research interests include social policy, poverty and inequality, family and child well-being, and family demography. She holds a PhD in demography and public affairs from Princeton University, a master's in public policy from Harvard's Kennedy School of Government, and a Master of Arts in Education from Claremont Graduate University. Cynthia, thank you for joining us this morning, and please take it away.
Well, thank you so much for having me. I am really glad to be able to be here and have this discussion with you and all the folks who are the participants. I'm going to share my screen and go through a few slides as we begin the discussion, and then really do look forward to a conversation with folks. Like Allison said, I have the privilege of directing our Prenatal-to-3 Policy Impact Center. And I'm going to start by telling you a little bit about what motivates our work and how we got things started and what it is that we're trying to contribute to the field. And I'm going to focus specifically today on our equity initiative and provide an example of what we're doing with regard to Medicaid as one example of an equity assessment that we're doing. Before I begin, I want to just make sure to state for the record that there are others on this call, as well as in the field, who are experts in Medicaid that we turn to for everything that we want to know about it. But this is an example of a policy that we've also been studying and what we wanted to share with regard to our equity assessment today. So just as a bit of background and motivation of where we begin, we really begin with the science of the developing child. That we know that this science tells us that our brains are the only organ that are not, when we're born, are not completely formed, that they're expecting input. They're expecting to be in nurturing, warm, loving environments that stimulate development. And this leads to self-regulation, executive functioning. And when our children, especially in the earliest years, are exposed to chronic adversity, that can really have biological and neurological impacts on their development, and it could lead to deficits across the lifespan, including early death. Now, we know that children are extremely resilient, that there's nothing that we can't really undo, but it does become much more difficult and even more costly to society if we don't try to make it so that from birth, we're setting those conditions in which children can thrive. We also know that systematically, our children of color, our children from lower levels of income, households with lower levels of income, these are the children who disproportionately are exposed to early adversity and lack the opportunities that they deserve to thrive. And so our work really builds on this science to try to address what we know from policy that might lead to better outcomes and especially more equitable outcomes. Our work also focuses on the fact that we have to nurture the caregivers in order for them to care for their children. This includes parents and ensuring that they have the resources and skills and support structures in place so that they can care for their children the way that they want to and their children deserve. And it also has to do with other caregivers like childcare providers and so forth in their lives. So our work really takes into consideration both direct benefits or impacts on the children as well as their caregivers. We also are motivated by the notion that there is not one magic bullet. It really does take a system in order to make it so that children live within these conditions in which they can get off to a healthy start. It takes a combination of broad-based economic and family supports and targeted interventions to meet the needs that are specific to each individual, and some way of identifying what those needs are and connecting children and their parents to those needs, or to those services. So we take this systems level approach to really understand what is the most effective policy or strategy that states can implement to try to create these sorts of conditions. And all of this work led us to identify 8 policy goals that range from making sure that children have access to the things, or children and parents have access to the things that they're eligible for, that parents have the ability to both work and care for their children at the same time, that work pays and that there's housing and food and economic stability within the household, that children are born healthy to healthy parents, and parents, we pay attention to both their physical and mental well-being, that we provide opportunities to enhance parenting skills and knowledge to really create those nurturing, responsive environments. And we do that also in childcare settings, and that we identify children's needs right from the start and get them into the services that can help them to really optimize the child's health and development. So these broad goals are where we begin. And as academics, we turn to the evidence and to say, what is it that actually creates these conditions? What are the policies that states can implement to make it so that we create these environments in which children can thrive? And in doing that, the Policy Impact Center is trying to contribute 4 resources to the field. One, we turned to like I said, these comprehensive reviews of the evidence, looked at more than 24 state level policies, and we have them available in our Prenatal-to-3 Policy Clearinghouse. And these evidence reviews are what I'm going to discuss more today. We are in the process of enhancing them so that they really have a much stronger equity focus. And I'm going to discuss that process as we go. But we also created our state policy roadmap. And this information stems from these comprehensive evidence reviews. And we identified the 11 most effective policies and strategies that states can implement that really impact prenatal-to-3 outcomes. This grid demonstrates how the policies are aligned with the 8 goals. And so I'm going to focus today on expanding income eligibility for health insurance, namely Medicaid expansion, And you can see that it's aligned with 5 of our different policy goals. So both access to services, increasing resources, getting kids off to a healthy start at birth, parents' health, and child development. We also look at these 6 strategies that are effective at impacting prenatal to 3 outcomes. The only difference between a policy and a strategy is that a strategy is something that works, but we don't have clear guidance from the evidence as to precisely how states should implement it in order to get the impact that we see in these randomized controlled trials of programs. But again, these are effective things that states can do to improve outcomes for infants and toddlers. We have, from the beginning, one of our founding principles is that we care about this because of the disparities in outcomes that we see that are systematic and persistent. We focus a lot on differences across race and ethnic groups, but we also pay attention to differences by socioeconomic status, geography, and other sorts of demographic characteristics. And the research is completely clear that state policy choices can create greater equity in both access and outcomes. And in our conversations with state leaders, though, we've come to learn that they often lack the guidance that they need on what policy choices they can actually make to better promote equity and not exacerbate inequalities or simply maintain the status quo. That there are a lot of folks out there who are striving to promote equity, but often lack the clear understanding of how policy choices that they have leverage over can actually shape equity, more equity in outcomes, more equitable outcomes. And so our equity initiative within the Prenatal-to-3 Policy Impact Center really aims to help state leaders develop and implement effective and equitable policies. And we have 4 different aims of our equity initiative, and 2 are geared more toward looking at our internal organization and making sure that the other team members and leaders are really educated about the issues of diversity and equity and inclusion, that we understand our own racial biases, and that we understand how to think about equity in all of the research that we do. Too often, researchers are not trained to think about the biases in our own research, especially those trained like me in rigorous kind of empirical methods, and RCT is just an RCT. We want to go further and really make sure that we understand how research has often perpetuated racism and inequality within our systems. We are also aiming to diversify our own team and to build the next generation of equity policy scholars. And we'll be hiring postdocs soon. So hopefully you guys can share that information with folks who would be interested. I'm going to focus mostly, though, on our external aims today. And they're related and kind of 2-pronged to get us to the same conclusion, which is identifying those state policy choices that can better, that can promote equity and enhance the outcomes for all children within a state, and really close those gaps. So I'm going to focus today primarily on our extensive equity-focused evidence reviews. That's a mouthful. I'm sure we'll come up with a better acronym at some point for this. But we have conducted comprehensive reviews of over 24 state-level policies, like I said, and they're in our clearinghouse. But our approach is to go back to those and really look at them with a much deeper equity lens. Because the way that we typically just conduct reviews, we say, what is it? Does it work? But we want to go a step further. And I'm going to share that approach with you today. We also, though, care deeply about listening to folks at the state level, both folks who are developing policies, implementing policies, and experiencing policies. And so our second prong to this approach is to conduct interviews and have discussions with state leaders and individuals within states so that we can really understand what are those policy choices, implementation methods that are leading to better outcomes and access for families. So I'm going to start with our evidence-based reviews. Like I said, we've conducted a couple of dozens of these, and now they are in our clearinghouse, and you can go and find out, everything that you want to know about the impact of the earned income tax credit on prenatal-to-3 outcomes, for example, or we have one for Medicaid expansion as well. And they are a really useful resource for states, for advocates, for academics. All the causal studies that have ever been done, we review and we say, what do we know and what do we still need to know? But there's a pretty standard way of conducting evidence reviews. You articulate what the policy is, what's the theory of change, why should it create these outcomes, lead to these differences in outcomes. We look at the rigorous evidence and identify what it is that it does impact. We are paying attention within those reviews to identify whether there are differential impacts. We call that subgroup analysis when we're doing kind of evidence reviews. Is the impact the same for all groups? We look at the return on investment. We look at the gaps, which are unfortunately sometimes very large in many of these studies, that they answer some questions but leave so many remaining. And then we look at how the policy is being implemented across states. So that's the basis that we started with. But we built on that, borrowing from lots of other frameworks that are out there, talking with various organizations who are experts in analyses with an equity lens. And this is, a rough kind of overview. We have more information we're happy to share of how we try to push these kind of standard evidence reviews further to not only ask what the policy is, but where did it come from and how did we get here? What's the historical foundation of this policy? What was it trying to solve? Did it even ever think about equity from the beginning? Was it actually legislated in order to exacerbate inequalities like Medicaid was? And importantly, when we're looking at that theoretical link, it's not just why, what is the theory of change? We want to really understand what the state leverage is to implement that policy, because that's the choices that states have. And in those choices is when they can either better promote greater equity or maintain the status quo or exacerbate inequalities. And so do they have the choice to determine who is eligible or what the payment levels will be or those sorts of things? And it's in that choice set that we really try to hone in and to see what is that variation across states, who is making choices that are leading to the greater access and outcomes for all race and ethnic groups. We dig in deeper on the causal impacts and really try to articulate what's missing in analyses. Too often, we don't do subgroup analysis, even when we should. Too often, our sample sizes are limited to tell us enough about subgroups, but we really want to push the causal studies to reveal where there is gaps that need to be filled. And then when we are looking at the variation across states and how the policy is implemented, we pay special attention to access of, the access to, the use of, the experience with the policy, and how that varies by race and ethnicity, not just across states, but within states as well. And then we try to identify the kind of outlier states, if you will, the states that seem to be perhaps beating some odds, that they have large populations of color, but they are demonstrating kind of relatively high levels of access and better outcomes for the populations. And other states that have high populations of color, but high populations of people of color, excuse me, but they are, not, you see there's wide disparities in access and outcomes. And so that we will identify those states and have discussions and conduct key informant interviews and really try to understand better what the policy choices are in each of those states. So I'm just going to use Medicaid as an example here. And for most of you on the kind of panel here, it is, this sort of background is, you could tell me much more than I can tell you, I'm sure. But Medicaid is such a fundamental policy. As you saw in our roadmap, it touches nearly all of the outcomes. And it is a resource that, without, so many folks would go without health insurance. Nearly 1 in 5 Americans is covered by Medicaid, about half of all of our births. And although it was launched in 1965, as you know, in 2010, it was modified quite substantially through the Affordable Care Act. And we're going to be paying most attention to this latest change, especially with the Medicaid expansion. But this was an important change in that if you adopt the expansion of Medicaid, you will then be able to cover childless adults within your state and adults who have incomes kind of between that income eligibility threshold that the state had prior to the ACA and up to 138% of the poverty line. And you're able to allow families with higher levels of income to purchase health insurance at subsidized rates. In 2014, our courts, they decided that it wasn't required, states did not have to expand Medicaid. And so that has led to quite a lot of variation across states in terms of when they've adopted it, and we still have several states that haven't. But the policy also continues to allow states to have latitude in who's eligible based on income, what they will cover, how much they'll reimburse, and so forth. And it's this sort of state latitude that we pay particular attention to. So when we think about what is the problem that it's supposed to solve and the variation by race, ethnicity, one of the outcomes that we look to is lack of health insurance. And we know that lack of health insurance varies quite a bit across states, but also by race and ethnicity. Because we're focused on prenatal-to-3 outcomes, we're really interested in the proportion of women who have lower levels of income and are childbearing age and who do not have health insurance. And you can see that there is a range across states. Texas happens to be the state in which nearly 48% of these women lack health insurance, up to our kind of best state, if you will, in which only 5% of these women lack health insurance. But there is wide variation within state, across race and ethnic groups, and this is the kind of US numbers. But you can see that Hispanic women of childbearing age have rates of lacking health insurance that are nearly twice that of their white counterparts and substantially higher than Black women. And this is just how this varies across states with regard to the proportion who lack health insurance. All of this information is available in the state policy roadmap that you can see at pn3policy.org. So I know there's a lot of numbers here, but we rank the states and demonstrate the proportion of women across states. And you're going to see a pattern over time of the southern states where I am and in Texas and many of our neighbors who will be typically towards the tail end of access and outcomes for families. But there's also a few states that have actually demonstrated that they can get access to families. So Louisiana, Arkansas, DC, which is not a southern state, but it is a state with a high population of people of color, also has some of the highest level of access. So these are the things that we pay attention to as we're looking through our analyses. So most of you know the history of Medicaid, and I'm just going to take a few minutes to talk about it. And the reason I am is that to me, it is one of the most important examples that we have when we really want to demonstrate that policy choices can institutionalize racism or can actually try to reduce racism and create greater equity. In schools of public affairs, schools of public policy, we use Medicaid as this sort of example. As you know, back in 1965, we passed the Medicare Medicaid Act, and we usually refer to this as this triple layer cake that had 3 different parts, and different constituents cared about different, each of these separately, and they were kind of amalgamated into one piece of legislation. We had Medicare with Part A and B to pay hospitals and doctors, and then we had Medicaid, which was geared toward individuals with low levels of income. Medicare from the start has been viewed as an earned benefit for the elderly. And all of the benefit levels, the eligibility criteria, all of that is set at the federal level, and that continues today. By contrast, Medicaid was paired with, at the time, aid to families with dependent children, and what we refer to as welfare. And the implementation of the program was left largely up to the states. And it was that decision, that compromise, if you will, that has really made it so that there's such variation in who gets access to health insurance and what is covered and so forth. States for Medicaid were allowed to decide whether or not to participate. They could set their own income eligibility thresholds. They could determine the scope of services that were covered, the payments that would be made to providers, and none of that was available through Medicare. And we had, states, especially the southern states, that were very resistant to both adopting Medicaid and making it so that folks would be eligible for it. And by pairing Medicaid with our welfare policies, it really allowed states to build on the racism infused into those policies that, during, many of you may be familiar with the fact that the Social Security Act of 1935, which is what initially established our welfare payments or aid to families, aid to dependent children at that time. Our southern states did not want that to extend to domestic workers, agricultural laborers, and this excluded nearly all Black men and women from receiving kind of any of the services available through the Social Security Act, including Social Security and other sorts of benefits. And our welfare laws allowed our states to set their own eligibility for who would be eligible for Medicaid, for welfare. And most states started to implement things like the suitable home criteria. You had to have, they judged a household as to whether it was suitable. And they excluded almost all Black families from receiving any benefits. And for decades, you had to qualify for welfare in order to also qualify for Medicaid. So this kind of was infused from the beginning to exclude particularly Black families, but it kind of extended to families of color writ large. And, with regard to actually adopting Medicaid back in 1965, 32 states across the US adopted Medicaid before even one former Confederate state did. So the southern states were really they were blatant. You can look through congressional testimony that they did not want to provide this benefit to the low-income individuals in their state, especially people of color. Anyway, throughout, despite the fact that Southern states have had the largest reimbursements from the federal government, they have provided the fewest services to the fewest people. And although this serves as this example of how we can literally legislate in racism, Medicaid and Medicare actually also serve as an example of how government can intervene and actually create a difference. The Johnson administration, they understood that there was a huge resistance to kind of serving, to actually taking Medicare, because they said, in order to get any sort of federal dollars, you're going to have to integrate the services in your hospital. They can no longer be segregated and exclude, at that time, especially Black families. And this was a firm commitment by the Johnson administration. They actually, held firm to that and sent out these kind of monitors to the hospitals, to kind of secret shoppers, to see if they would be able to be served if they were people of color. The hospitals couldn't fake it. They really had to integrate their services. And, 3 months before the program actually going into effect, only 15% of hospitals in our 7 most segregated states had decided to opt into the program. The financial threats did work, though, and hospitals did integrate. Still, there are many problems that remained. It's not as if it was a perfect thing, but it does show that the pressure that governments and policies can put on our states and communities can make a big difference in how they act. Now, this was back in 1965, but this still holds through to today in terms of, if we are serious, we have to be intentional about the policy choices and how we go about identifying where there are racist policies in place, where there exist inequities, and be intentional about eradicating those. All right, so I want to talk now about the impact of Medicaid and Medicaid expansion in particular on prenatal-to-3 outcomes. And again, in our roadmap, we have what we call our impact tables that show from all of the causal studies what the impact is, and particularly on prenatal-to-3 outcomes. And we see that states that expanded Medicaid show improvements for folks with regard to preconception care, postpartum care, getting the recommended screenings. They also have easier time paying their medical bills, and are not as likely to delay healthcare because of lack of cost. And for some of the things that we're particularly interested in with regard to this equity assessment is that states that have expanded Medicaid actually see that they have been closing some of the gaps in birth outcomes for between Hispanic and white and Black and white families. So a couple of examples of where we look at infant death rate is improved for Hispanic families among states that expanded Medicaid. And we see that maternal death rates are improved, particularly for Black families or Black mothers in states that have expanded Medicaid. So the problems still persist, though, and these are the things that we are monitoring over time. And as states begin to expand Medicaid, and we're monitoring to see that we try to close these gaps, both across states and within states across race and ethnic groups. So these are just a few of the maternal and child health outcomes, or the outcomes that are most relevant to Medicaid. And you can see that these are still big disparities across race and ethnic groups with regard to preterm births, And when you look at the pattern of the dark squares, or the states with the highest level of preterm births, you're going to start to see this pattern of where our families seem to be struggling the most. And it's highly correlated with states that have high populations of people of color. We look at low birth weight, and again, our Black children are much more likely to be born at low levels of weight at birth as compared to white or Hispanic children. And the patterns kind of where it is across the country fall mainly toward our southern states. If you look at our infant mortality rate, the rate is more than twice that for Black children as it is for white children. And again, the pattern shows you kind of where the rates are the highest. When we look at mental health of our mothers, you can see that the gaps are not quite as big as some of these other outcomes that we've been looking at. And that here the kind of pattern doesn't hold quite as much as it does with regard to the birth outcomes. When we look at child poverty, which is obviously one of the most important outcomes that we want to track over time for children, we see that children under the age of 3, Hispanic children are more than twice as likely as white children, and Black children are more than 3 times as likely as white children to be living in poverty. And when we look at the patterns of the state, we see that it's still largely our southern states in which that have the highest levels of poverty. Child maltreatment rates, we see that the rates vary wildly by race, ethnicity, especially for our Black children that are 2 to 3 times the rate of white and Hispanic children. And again, here the patterns are a little bit more dispersed. This has to do more with reporting than incidents, but this is the patterns throughout the country. And then what we want to pay attention to, though, like I said, is what are those policy choices that states have, and how do these vary across states? And what we're trying to do is to find that correlation between the policy choices and the outcomes that we just observed. And when we think about the policy choices that states have to affect equitable access, the experience, and outcomes, there's a range of policy choices that we can focus on. One is just, did you adopt the policy or not? With Medicaid, it's also we're looking at the income eligibility levels, the types of services that are covered, the level of administrative burden, the reimbursement rates, the stigma that's attached to whether healthcare is a right in your state or whether it's seen as something that is a limited benefit. And we also look to see the states that are using data to track measures with regard to folks, if access is equitable and experience and outcomes. Are we actually using data and holding ourselves accountable? And so that's something that we look at within states as well. I'm just going to run you through some of these with regard to adoption and income eligibility and services. This is just an example of for every state, we've created a state policy roadmap. So we have our large roadmap, and then we have specific ones for states that just show you where your state would stand on some of these outcomes. So this is the one from Texas where I am, and it demonstrates that Texas is one of the states that has not adopted Medicaid expansion. It has the lowest income eligibility threshold of all states, and it has the lowest, the highest level of uninsured. I'm going to skip through just in the interest of time to just demonstrate also in our roadmap the states that have adopted Medicaid expansion. So 37 states have, including DC, as of October 1st. There are a couple of states, Oklahoma and Missouri, who have adopted it through legislation, but it's not yet implemented. Oklahoma might be in July, Missouri may not be. And then there are other states that are considering this, but for the most part, with the new American Rescue Plan, there's greater incentives for states to do this. So we're still hopeful but to date they have not. And what we see when you look at this pattern after pattern is the difference between those states who have adopted Medicaid expansion and all of the different access and outcome, the measures with regard to access and outcomes. And when we look at income eligibility thresholds, so for those states that have not adopted Medicaid expansion, childless adults are not eligible for health insurance. In those states that have, most states have limited to what the federal requirement is, which is 138% of FPL. But you can see that DC has extended that up to 215%. And when we look at parents, you can really see the difference in those states that have not adopted Medicaid. So there's Texas and Alabama at 17 and 18% of the federal poverty level, Wisconsin up to 100% of the federal poverty level, but they're all substantially lower than the states that have adopted Medicaid. So this means that these are folks who are not eligible to receive Medicaid, but they also have incomes too low to buy insurance on the marketplace. When we look at the types of coverage that varies across states, we see that there are 6 states that require Medicaid to pay for maternal depression screenings. There are 27 states that require Medicaid to pay for developmental screenings. There are 4 states that allow Medicaid to reimburse for doula care, 10 states that provide enhanced reimbursement for group prenatal care. States vary in their use of Medicaid for early intervention services, whether they pay for comprehensive screening and connecting programs, home visiting programs. It still varies quite substantially. And those states that have adopted Medicaid expansion are able to use more of their savings from doing that to actually provide more of these sorts of services. So after we have done this kind of empirical look at what do we see with regard to the policy choices that states seem to be making in the numbers, we want to start to identify states that we want to investigate further and talk to find out kind of what are you doing that actually seems to be working, and what choices are you making that really are not for our families. And so we identify some states that are have large populations of people of color with relatively higher levels of access and or better outcomes, or doing something innovative. So we looked at states or areas like DC, Hawaii, Louisiana, Arkansas, New Mexico. We also looked at states with large populations of people of color that have relatively low levels of access and or poor outcomes. And Texas, Alabama, Florida, Oklahoma, Mississippi. And we want to have conversations to learn from these state leaders. What is it that is leading them to make these policy choices, to expand Medicaid or not, to set where they set their income threshold for eligibility, what some of their efforts have been to promote greater access or lack thereof, how they have modified their state plans to include various elements for coverage. And we really want to talk to the individuals who are eligible for Medicaid, or at least with the organizations that are grassroots and working within states who really understand the lived experience, so that we can understand, what access looks like and what those barriers are when folks do use the services, how they experience that, and what some of the challenges are there. And it's from this combination of kind of this empirical look and this more experiential look that then we will create this kind of specific set of policy choices that states can make to better promote equity, such as adopting Medicaid expansion, setting their income threshold higher, maintaining coverage following a birth, making it so that when you enroll for one service that you can have access to another, that we set reimbursement rates that are high enough to incentivize providers to actually offer services, and so forth. So this is just a limited list. But we're going to be doing this for all of the policies that we evaluate. We're looking at paid family leave, for instance. We're looking at child care subsidies. We're looking at SNAP. those are kind of the next on our list that we're paying attention to. And what we're wanting to do is just to really learn from states what it is that we, that we can do differently that will actually lead to real policy changes and changes in access and outcomes for our families and close these persistent gaps. So I'm going to stop there and turn it back over to Allison. But I appreciate the conversation, the opportunity to have a conversation with you, and also just encourage you to reach out to us and share with us what we should know about what your state is doing, what we should know more about our equity assessments, and to learn from you as we kind of go through this with you in partnership. So thank you for this opportunity.
Great. Cynthia, thank you so much for your presentation. This was fascinating. And I think folks who are not, maybe even folks who do focus on Medicaid in their jobs may not be familiar with the history of the program and its origins. So I appreciate you taking the time to share some of that with us today. And we will now move to a question and answer period. So folks, please feel free to start typing questions into the chat, either using the Q&A function of Zoom, or you can type directly into the webinar chat, whichever you prefer. And we have had a couple of questions come in already, so I will get to those in just a moment. But I did just want to reflect for a moment and let people start to think of their questions. So this is, I've found this very useful coming from the perspective of the Maternal Health Learning and Innovation Center is focused on improving maternal health and eliminating inequities in maternal health outcomes. The Prenatal-to-3 Policy Impact Center is focused, as its name would suggest, on the prenatal-to-3 period towards improving child outcomes for all children. And I hate to separate the dyad in that way, in that kind of arbitrary way, but we have a stated focus on 1, maternal health, and 2, child health and child outcomes. And Cynthia, what I'm curious about is, as you've been going through the development of these criteria and looking at Medicaid, do you think that there will be takeaways that, as you start to apply criteria to other policies from your roadmap, that there will be, are there starting to be common themes? Or are you expecting common themes that, in addition to the policies that you're reviewing, this can and will be applicable to the review of policies for maternal health outcomes and looking towards equity?
Yeah, I appreciate that question. And I do understand the distinction between maternal health outcomes and child outcomes. But one of the first things I was saying was that we really understand how that dyad is just completely connected. You cannot have healthy children without healthy adults. And we focus on all the caregivers in a child's life, but one of our primary focus is on the mother, not just as a vehicle for carrying the child. Too often when we think about that, we're thinking, well, we just need to keep her healthy. That's why we provide her with pregnancy Medicaid, to be honest. It's often seen as she's the carrier of the child, and so we're really providing services for the child. And that's not the way we think of it. I think personally that we start with the prenatal period because that is such an important period for both mom's health and it's related, to the child's health as well. But when we think about the policies and how they, might be applicable to a range of outcomes, I think that the questions remain the same. The outcomes here are not necessarily driving our evidence reviews. They may drive the studies that we look at. They may drive the type of people within a state that we want to speak to. Where we may want to, if we're looking at a child care policy, talk to folks who are running child care centers. If we were looking at perinatal health outcomes, we would want to speak more directly with folks who are serving moms in that capacity, for instance. So I think the type of people that you would interview, the types of outcomes that we're exploring, the types of studies that lead us to those outcomes, those things differ policy by policy in our assessments. The types of questions, I believe, are really similar. And the themes have to do with, did we actually develop this policy with the intention of creating greater equity? Did we actually develop this policy with the intention to exclude folks and make it difficult for people to access services? How intentional are we being in allowing folks who are eligible for the policies to actually access them? And there's several other kind of common threads, but those sorts of things apply from policy to policy, regardless of the outcome.
Thank you. I appreciate that. And we had a question come in from Mimi Niles that I want to share. And this is related to your assessment of Medicaid. Do you have thoughts on not just Medicaid coverage, and will your assessment look into not just Medicaid coverage, but what services Medicaid covers that directly impact maternal health equity? And Mimi provides some examples, such as community health workers, birth centers, community midwifery care, and mental health services.
Yeah, thank you for that question. And again, I gave some examples at the end of the types of things that states can choose to cover or not, right? So we noted that there are 4 states that allow Medicaid to pay for doulas, for instance. There are 10 states that allow an enhanced Medicaid reimbursement for group prenatal care. So those are just 2 examples. But the types of things that, Mimi, you bring up are the exact sort of things that we want to investigate when we are talking with state leaders about the choices that they made. And so it's, we can collect anything that's available kind of at the national level. We can ask states exactly what they're doing. But what we want to see are patterns or trends of states that are really taking this seriously and investing in kind of multiple types of services that will actually improve these outcomes. There are other things, obviously, besides Medicaid that improve the maternal outcomes, and understanding how Medicaid pairs with the decision to implement which AIMS bundles to implement, or how their perinatal health collaborative is set up and structured, and what recommendations it's making. And we want to understand all of that as well. Right now, the policy choices I gave you were pretty simplistic, but yes, those are the types of things. It's those decisions that allow for inequities across states and access to those services within a state that perpetuate the inequalities across different demographic groups.
Great, thank you. And folks, please keep typing in your questions. These are great. Again, either through the Q&A function or through the chat is fine as well. We have a question about Medicaid expansion from my AmChip colleague, actually, Stacy Collins. And Stacy asks, based on your research demonstrating the success of federal requirements for hospital and benefit standards that have been effective in reducing disparities, would research support federal intervention to expand Medicaid in the remaining holdout states, particularly since the carrot of the FMAP bump, the federal matching rate, hasn't been successful? And I asked Stacy a clarification question, if by federal intervention she meant another go at requiring states to expand Medicaid, despite the Supreme Court ruling that we have, and she answered yes. So any thoughts on that?
So if I'm being 100% honest, I am not exactly sure what legal what the legal decision was that made it so that states have the authority to choose to expand Medicaid or not. So I don't know how negotiable that is, or if it can be legislated around. But we definitely see that there is huge benefits to expanding Medicaid for families, for the moms, the other adults, and especially for children. And we know it actually saves states money. And so the reasons for not doing it at this point don't seem to be financial, or that we just don't know if it's going to work. I don't know how you can incentivize more than what the American Rescue Plan did and the CARES Act initially. I guess if you made it so that it was 100% coverage, that perhaps that would be the last great incentive, instead of just these very high FMAPs. And for the expansion part, now it's at over 90%. So I can't actually say whether it would be possible for there to be a legislative kind of intervention here, or if there is a legal kind of decision that would prevent that. But the only incentive I can think of next is just for the federal government to cover the whole cost.
Great, thank you. We just had two more questions come in quick succession, so we'll try and get to both of them. Mara is asking if anyone, so Cynthia, if you have a response, great, or if other folks listening in have resources, does anyone have a listing of which Medicaid covered programs states have implemented? Cynthia mentioned doula coverage as one such program, wondering what the other programs are and which states have chosen to implement them.
So I would love it if folks were to share their resources, because we will tap into those as well. And I know that the Center for Children and Families at Georgetown and the Kaiser Family Foundation, those are two groups that I would look to. They probably know more than anyone about what all states are doing. We have a pretty broad list with regard to things like screenings and doulas and how their perinatal health collaboratives are set up and things like that. But I don't know everything that would be kind of on the list that you would like to see. But I'd like to get a copy. I'd like to understand the list of the programs, and then we can start to figure out which states have which. But it's typically written in the state's Medicaid plan. If it needs to have kind of a specific call out for it, but it is, I don't know every service in every state at this moment, but it's a great question and really important.
Great, and perhaps a resource that someone somewhere can develop and would be of interest, I think, to a lot of people on this call. I do have one more important question I want to include, and then we'll close out today. So Penelope, and forgive me if I'm mispronouncing your name, if racism continues to be taught in education settings, how are healthcare professionals given space within class frameworks to see these and discuss? The racist education system plays out in all health and disease. So in Medicaid, for maternal care, we see this play out. How does education and equity combine in policy change to address the racism in healthcare providers and policymakers' education? How are you all addressing this in your prenatal-to-3 work?
I was listening instead of reading, and I'm a better reader than listener. So I'm hoping that I got all of the question, and forgive me if I don't address it all. But what I think the heart of the question is that the folks who we are entrusting to make policy and implement services and provide supports for our families, they themselves, we have racial biases. We have not been educated as well as we need to be to really understand the roots of racism within our education, our medical or social support or economic systems. We sometimes don't recognize that they're even there. That kind of walking through with ignorance can cause great harm. And the goal of the equity assessments that we're producing are to try to provide a resource to educate both policymakers as well as academics a bit more. I'm a teacher. I teach at our school, mostly graduate students who are going to go out in the world and be policy leaders in some capacity. And it is imperative that we have them fully understand that the policy choices that we have made have led us to exactly where we are, and that it's our responsibility to make different choices if we expect different outcomes. And so that's just going to take persistence and intentionality to actually shake things up. But I will also say that Texas right now is considering a bill to make it so that we can't actually talk about racism or white supremacy or white privilege or critical race theory or any of these sorts of things within our public schools. So there's one step forward, maybe two steps back, but it doesn't mean that we can stop. We just have to be very intentional about this.
Great. Thank you so much, Cynthia, for your presentation today and sharing your thoughts during the Q&A. I would invite everyone to, we're going to have these reflection questions copied into the chat as well. Some thoughts, questions to ask yourself and maybe bring back to your team. What were your main takeaways from the webinar? What questions did this raise for you? And what applications or action ideas has this session triggered for you? And one quick plug for an upcoming event, August 30 to 31 this year. Please save the date for the National Maternal Health Innovation Symposium. This is the second annual event of this kind hosted by the MHLIC. It's free, it's virtual, and there's an open call for proposals right now that closes June 4th. And you can go to maternalhealthlearning.org for more information. And with that, I will say thank you for joining today's webinar. Please take a few minutes to complete the evaluation survey via this link, and we'll copy that into the chat as well. I think Alice actually already did so. And please enjoy the rest of your day and the weekend ahead. Thank you so much.